Imagine you are an ER nurse,
Okay.
and two patients just roll through the double doors from this massive car crash.
Oh, wow. Right into the deep end.
Right. So one of them is screaming at the top of his lungs, and there is just a geyser of blood shooting from a mangled leg. I mean, it looked like a scene straight out of a horror movie.
Naturally.
But the other patient is sitting perfectly still. They look, mostly fine, actually. But when they try to talk, there is this incredibly subtle, like high-pitched squeak every time they take a breath.
Oh, yeah. That's bad.
Right. Because if you run to the screaming patient first, your quiet patient will be dead in 3 minutes.
Yeah, it is the absolute ultimate trap for a novice responder. I mean, your eyes are just completely hijacked by the dramatic bleeding.
Of course they are. It's human nature.
Exactly. But your training has to override your instincts.
And welcome to today's deep dive, everyone. We are looking at a really fascinating stack of sources today. We've got clinical protocols, medical history, triage frameworks, and the actual philosophy driving modern nursing exams.
It's a lot of ground to cover.
It really is. Our mission today is to unpack the intensely high-stakes world of prioritization. So, if you are studying for your medical boards right now, obviously you know how critical this is.
Oh, yeah. It's everything.
But even if you are just someone who's fascinated by how human beings make rapid-fire, literal life-or-death decisions under extreme pressure, this deep dive is absolutely going to change how you look at problem solving.
I completely agree.
Because we are exploring how nurses fuse clinical knowledge, meaning the physiology of what could kill someone, with workflow management, meaning what to physically do first. And they do this in a single split-second judgment.
Right. They basically have to instantly merge the what's wrong with the what now.
Exactly. Okay, let's unpack this, because where do we even begin with a concept this massive? Like, was there a specific moment in history where someone finally sat down and wrote out the rules for who gets saved first?
Well, to find the origin of that, we actually have to step far away from, modern sterile hospital rooms.
Okay, where are we going?
We have to go back to the battlefields of the 1800s.
Wow, really?
Yeah. So the foundational word we use today is triage, right? Which comes from the French verb tria, which simply translates to sort.
To sort, okay.
Right. And the person credited with weaponizing this concept, and I use that word intentionally, was a man named Dominique Jean Larrey.
Larry, wait, he was Napoleon Bonaparte's chief surgeon, correct?
He was, yeah. So during the Napoleonic campaigns, particularly during that brutally freezing retreat from Russia in 1812.
Right, the famous retreat.
Exactly. Larry observed this incredibly chaotic and highly ineffective medical response because before him, wounded soldiers were treated based on their military rank.
You're kidding?
No, seriously, like a general with a twisted ankle would absolutely get a doctor's attention before a private with a musket ball in his chest.
That is insane.
Or, alternatively, surgeons just treated whoever was physically dragged off the field first.
Just totally random.
Total chaos. So he essentially walked into that chaos and instituted a pure threat level system.
Right, so he stripped away rank entirely.
Entirely. Larry began sorting the wounded strictly by the severity of their physical injuries, and he also realized that speed itself was a medical intervention.
Because you can't just wait around.
Right, so he pioneered these horse-drawn flying ambulances to actually retrieve the wounded while the battle was still raging, rather than waiting for the shooting to stop.
Wow. But the sources point out something really fascinating about his underlying motivation for all this.
Yeah, it's not what you'd expect.
Right, because we tend to view doctors through this lens of pure humanitarian mercy, right? But Larry's triage system, it wasn't born out of a bleeding heart.
Not at all. It was born out of cold, hard military logistics.
Which makes sense for Napoleon's army.
Yeah. The explicit goal was to evaluate soldiers, find the ones who were treatable, patch them up, and then shove them back onto the front lines as quickly as possible.
Because they needed a functioning army.
Exactly. Preserving the strength of the fighting force was the priority, not necessarily, comforting the dying.
It's a pretty radical shift in thinking when you compare it to how normal society operates. Like, we are deeply conditioned by what I call the deli counter system.
Oh, right. First come, first served.
Exactly. You take a ticket, you wait your turn, and universally, everybody considers that fair. But Larry essentially walked up to the deli counter, ripped the ticket dispenser off the wall, and declared that fairness just doesn't matter when survival is on the line.
That is a great way to put it. And that military arithmetic, it migrated into civilian medicine over the next century, and it really became the absolute prime directive of modern nursing prioritization.
Which is?
Treat what will kill the patient soonest first.
Which sounds completely obvious until you are actually standing in a chaotic room with 5 injured people.
Oh, 100%.
Because knowing that you must treat what kills fastest is one thing.
Yeah.
But how do clinicians actually measure that? I mean,
Yeah.
how do you look at a complex human body and instantly calculate the countdown timer on their life?
Well, you rely on the ABCs.
Okay, the famous ABCs.
Right. But to understand how those became the gold standard, we really have to look at how disjointed trauma care was up until the late 1970s.
Wait, the 70s. So who actually standardized this?
Yeah.
Was it like a gradual evolution, or did someone finally sit down and write a manual?
It was actually born out of a specific harrowing tragedy.
Oh, really?
Yeah. In 1976, there was an orthopedic surgeon named Dr. James Steiner. He was piloting a small plane with his family over Nebraska, and the plane crashed into a cornfield.
Oh, my God.
Yeah. His wife was killed on impact, and he and his children sustained severe, complex injuries.
That's horrifying.
It is. And when they eventually flagged down help and arrived at a local rural hospital, Dr. Steiner was just appalled by what he saw.
I can only imagine. I mean, you survive a plane crash, you think you're finally safe, and then you realize the hospital doesn't even know what to do with you.
Right. The medical staff there, I mean, they were well-meaning, sure, but the care was disorganized and completely inconsistent. They just didn't have a systematic way to evaluate multiple trauma victims.
So they were just winging it.
Basically. And Steiner realized that surviving the physical accident was merely phase 1. Surviving the chaotic hospital response was phase 2.
Wow.
So that experience drove him to collaborate with colleagues to create the Advanced Trauma Life Support Program, or ATLS. And that is really where we get the widespread formalization of the ABCs.
Airway, breathing, circulation.
Yes. The logic is brutally straightforward.
Right, because without an open airway,
oxygen can't get in, right, making your lungs useless. And without breathing, oxygen doesn't get into the blood. And without circulation, a beating heart, that oxygenated blood never reaches your brain.
it's a domino effect.
Exactly. And modern nursing actually expands this sequence to A, B, C, D, E.
Okay, what are the D and E?
They add disability, which means conducting a rapid neurological check to see if, the brain is swelling, and then exposure.
Exposure, meaning you have to physically undress the patient.
Right, because you cannot treat a hidden femoral artery bleed if the patient is wearing thick, blood-soaked winter clothing. You expose the skin to find the hidden threats and then immediately cover them up to prevent hypothermia.
Because hypothermia worsens bleeding.
Right. Dramatically worsens it, yes.
Okay, let's bring this back to that car crash scenario from the beginning, because it highlights how this framework prevents nurses from being distracted by the visual drama.
Oh, the screaming guy versus the quiet guy.
Yes. We have the patient with the mangled, bleeding leg and the quiet patient with the squeaky voice. Tell me about the physiological mechanics of that squeak, what the sources call stridor. Why is that the immediate threat?
Okay, so stridor happens when the airway, like the trachea or the larynx, is severely swollen or obstructed.
Okay.
Imagine a wide pipe that suddenly swells shut until only a tiny pinhole remains. The lungs are desperately trying to suck air through that tiny rigid gap, which creates that high-pitched squeaking vibration.
So it's literally an alarm bell that the pipe is about to close entirely.
Exactly. When you hear stridor, you are listening to an airway that is perhaps minutes or even seconds away from complete irreversible closure.
And once that happens, the patient suffocates.
Right. Whereas the patient with the mangled leg, while visually terrifying, is dealing with a circulation issue.
The C and the ABCs.
Yes, unless it is a catastrophic, geyser-like arterial hemorrhage that will drain their blood volume in 60 seconds, a standard venous bleed gives you a slightly longer window to apply a tourniquet.
Meanwhile, the quiet patient is suffocating right in front of you.
Exactly.
It is just a profound mismatch between what looks most urgent and what actually is. But you know what I find incredible in our sources?
What's that?
That even these life-or-death foundational rules are subject to change based on new data.
Oh, right. What's fascinating here is the 2010 pivot by the American Heart Association.
Yes, the CPR changed.
Right. For decades, CPR was drilled into everyone's head as ABC, airway, breaths, compressions. You tilt the head back, you give 2 rescue breaths, then pump the chest.
But they completely flipped it, right? To CAB compressions first. Why did they do that?
Well, researchers analyzed real-world cardiac arrests, and they found a fatal flaw in human behavior. Bystanders were wasting massive amounts of precious time trying to figure out the exact right head tilt maneuver.
Or they just didn't want to do mouth-to-mouth on a stranger.
Right, they were too hesitant. And during that hesitation, zero blood was moving to the brain.
They were basically losing the patient while trying to follow the acronym perfectly.
Exactly. The AHA realized that the blood already has enough residual oxygen in it to sustain the brain for a few minutes, provided you physically pump it.
So they changed the rule.
They did start mashing on the chest immediately. Millions of medical professionals and everyday citizens had to entirely relearn the most famous medical acronym backwards just to eliminate that human hesitation.
That perfectly illustrates how prioritization is this, like, dynamic science. Okay, so the ABCs solve the first 3 minutes of an emergency.
Right.
But a nurse's shift is 12 hours long.
Oh, absolutely.
Once a patient isn't actively dying, how do you prioritize the next 11 hours and 57 minutes of care? Because to figure that out, modern nursing borrows heavily from psychology, specifically Abraham Maslow.
Yes. Maslow's 1943 paper, A Theory of Human Motivation, was a seismic event in psychology.
A total game changer.
Totally. At the time, Maslow was deeply frustrated. He felt his field was trapped in this false binary.
How so?
Well, on one end, you had Freudian psychoanalysis, which was oppressively focused on neuroses, pathology, and the broken mind.
Right, digging through childhood trauma to figure out why you're miserable.
Precisely. And on the other end was behaviorism. Think of B.F. Skinner and his rats pulling levers for food pellets.
Right, classical conditioning.
Maslow argued that behaviorism treated humans like empty, mindless stimulus response machines. It entirely ignored our rich inner lives.
So what did he do?
He wanted a third force, which became humanistic psychology. Instead of studying the broken or the conditioned, Maslow decided to study the healthiest, most high-achieving people he could find. Minds like Albert Einstein and Eleanor Roosevelt.
He wanted to reverse engineer what makes a human being thrive.
Exactly. So he proposed that human motivation is driven by an ascending hierarchy of needs.
Right, starting from the bottom.
At the very foundation are our physiological requirements: oxygen, water, food, sleep.
The absolute basics.
Once those are secure, we seek safety and security, then love and belonging, then esteem and respect.
And at the very top.
Finally, at the pinnacle is self-actualization, the desire to reach our absolute ultimate potential.
And nursing education actually adopted this as a filtering mechanism.
It did, yeah.
It gives students an intuitive way to rank competing demands. The golden rule the sources mention is airway and breathing before feelings.
It creates a really clear boundary. Imagine a patient recovering from a major surgery. They are highly anxious, crying, and begging you to explain their biopsy results.
Which is a huge emotional need.
Huge. But you notice their oxygen saturation monitor is dropping to 88%.
Oh boy.
Right. Maslow's logic dictates you must aggressively fix the physiological oxygen problem before you even attempt to address the psychosocial anxiety problem.
Because a patient who is actively suffocating cannot cognitively process your emotional reassurance anyway.
Exactly. It just doesn't work.
And within that framework, there is another incredibly useful tool, the actual versus potential rule.
Yes. It solves the dilemma of competing physical needs. Generally, a problem that is currently happening outranks a potential risk.
Right, so like...
Well, if you have patient A who is experiencing moderate pain right now, and patient B who is simply at a high risk for falling out of bed but is currently tucked in safely, you go give patient A their pain medication first.
But the sources note that a potential risk can instantly hijack the priority list.
Oh, entirely. If you are walking toward patient A with that pain medication and you hear patient B trying to climb over their bed rails,
the potential problem just transformed into an immediate physical threat.
Exactly. Patient B jumps to the front of the queue and you drop what you're doing to prevent the fall.
Okay, here's where it gets really interesting for me. Because if you say the name Maslow, everyone immediately pictures the pyramid.
Oh, yes, the famous pyramid.
It is arguably the most famous visual in the history of psychology. It's in every intro textbook, it's on dorm room posters, it's in every corporate HR PowerPoint presentation you've ever sat through.
So true.
But our sources reveal a massive historical blind spot. Maslow never drew the pyramid.
It is such a stunning piece of historical revisionism. You can read his entire 1943 paper, top to bottom, and you will not find a single triangle.
So where'd it come from? Who drew it?
The pyramid was actually invented in the 1960s by business management consultants.
You joking?
Nope. They took Maslow's nuanced, fluid ideas and flattened them into a rigid, color-coded triangle to sell corporate motivation training to executives.
Wow. Which means nursing students are often memorizing a secondhand, oversimplified corporate management diagram to make medical decisions.
Yes.
That seems, honestly, slightly dangerous.
Yeah.
What gets lost when we force complex human needs into a corporate triangle?
Well, we lose the fluidity of the human experience. I mean, Maslow himself didn't believe we move through these stages like a video game, unlocking one level before we are allowed to access the next.
Right, life isn't that linear.
It's not. Furthermore, late in his life, he actually added a tier above self-actualization called self-transcendence.
What's that?
It's the desire to connect to something greater than the self, which, of course, was completely left off the corporate pyramid.
Of course. And there are pretty severe critiques of using this strict hierarchy in a hospital setting, right?
The critiques are substantial. Cross-cultural research demonstrates that the hierarchy carries a heavy Western individualistic bias.
How so?
It places personal self-actualization at the absolute peak, whereas many Eastern or indigenous cultures might place collective harmony, elder respect, or relational needs far higher than individual achievement.
That makes total sense.
Moreover, people who are deeply food or safety insecure don't just stop loving their families.
Right. You don't pause your need for connection just because you missed lunch.
Exactly. And if a clinician applies this flattened pyramid too rigidly, it can actively endanger patients.
Give me an example of that.
Consider a deeply suicidal patient. Under a strict, literal interpretation of Maslow, physiological needs always come first, right?
Right.
So if that suicidal patient complains of mild nausea, a rigid follower might conclude they must treat the physiological nausea before dealing with the psychological safety risk.
Which is obviously a catastrophic failure of judgment.
Hmm.
A suicidal patient's psychological safety must absolutely override a minor physical complaint.
Exactly. The hierarchy is meant to be a heuristic, a general rule of thumb, not an unbreakable law of nature. Context is everything.
Which actually brings us to the most extreme context possible. We've talked about the ABCs for a single patient and Maslow for managing a small group on a hospital floor. But what happens when the entire medical system breaks down?
Oh, right.
When you are dealing with a mass disaster like a train derailment or a structural collapse, and you have 40 patients but only 2 medics.
Yeah, that's when you enter the realm of disaster triage. And this requires a complete inversion of the ethical compass we just discussed.
In what way?
Well, in the U.S., responders often use a system called START, simple triage and rapid treatment.
And the sources mentioned this was developed by Ho Hospital and the Newport Beach Fire Department in California. How does it physically work in the field?
It is designed for terrifying speed. A responder must evaluate a victim in under 60 seconds.
60 seconds, that's nothing.
It's incredibly fast. They use the RPM check, respiration, perfusion, and mental status.
Break down perfusion for a moment. How do they check that in under a minute?
They check capillary refill. So they press down hard on the patient's fingernail until the nail bed turns white. Then let go and count how many seconds it takes for the pink color to return.
Oh, okay.
If it takes longer than 2 seconds, it means blood isn't circulating properly to the extremities, indicating severe internal bleeding or shock.
Wow. Just from a fingernail.
Yeah. And based on that quick RPM check, the patient receives a colored tag.
Right, the tags.
Red means immediate. They have life-threatening injuries but can survive with rapid intervention. Yellow is delayed, meaning serious but stable. Green is for the walking wounded.
Okay.
And then there is the black tag.
Yeah. This is the part of the sources that genuinely stopped me in my tracks. The black tag is for the expectant, meaning their injuries are so catastrophic that they are incompatible with survival given the limited resources.
That's right.
Wait, so the absolute sickest patients, the ones who normally would get an entire team of surgeons and every machine in the hospital, are deliberately treated last or entirely abandoned.
They are provided palliative comfort if possible, but no life-saving resources are expended on them.
That is a total ethical flip. I mean, we expect the most desperate person to get the most help.
In a functioning hospital, yes, but in a disaster, normal hospital ethics will lead to a systemic massacre.
A systemic massacre, wow.
It is a grim mathematical reality. If you have 10 salvageable patients who need immediate tourniquets and chest seals, and one profoundly crushed patient who is unlikely to survive even with maximum surgical intervention.
pouring all your time and bandages into that one unsalvageable patient guarantees the other 10 will bleed to death waiting for you.
Exact.
So the explicit stated goal of disaster triage is unequal care.
The goal is to maximize total survival. You are forced to deliberately withhold resources from the most desperate cases to save the most salvageable lives. It is literally the trolley problem brought out of the philosophy classroom and dropped into the real world.
But this isn't just something that happens in earthquake rubble, right? Because this kind of algorithmic sorting happens inside modern, well-led hospitals too.
It does, yes. Modern emergency departments rely on standardized scoring algorithms to remove human hesitation. They use frameworks like the Emergency Severity Index or ESI, which is a 5-level system.
How does that work?
Level 1 requires immediate, all-hands-on-deck resuscitation. Level 5 is, a minor rash or a prescription refill.
But relying on math and algorithms to prioritize human life has a really dark side.
Yes, it certainly can.
The sources highlight a highly controversial example from the COVID-19 pandemic in 2020.
Right. During the early surges, hospitals were terrified they would run out of mechanical ventilators, so several U.S. states began drafting crisis standards of care protocols.
Which are basically algorithms to decide who gets a vent.
Exactly. Algorithms designed to automatically calculate who would get a ventilator and who wouldn't if the system reached total capacity.
Now, we are looking at this purely through the objective historical record provided in the sources. What exactly went wrong with these algorithms? Because the sources single out drafts from Alabama that actually sparked a massive federal response.
Right. So the early drafts of these scoring algorithms effectively deprioritize people with intellectual and developmental disabilities or individuals with certain chronic conditions.
Wait, how do they do that?
Well, the math was set up in such a way that these patients would be placed at the very bottom of the ventilator waitlist, effectively denying them life-saving equipment based on their pre-existing baseline.
It's like setting up a VIP lane at a nightclub. But the algorithm secretly decided beforehand that anyone wearing glasses isn't allowed in the VIP lane. Like, the bouncer at the door isn't biased, he's just blindly following the math. But the math was rigged by the club owner.
That is a perfect metaphor, and it triggered immediate federal civil rights complaints to the U.S. Department of Health and Human Services.
I can imagine.
Several states were forced to drastically revise their protocols under federal scrutiny. It was a stark reminder that pure algorithms don't eliminate human bias, they simply hide it.
That's a chilling thought.
It is. An algorithm can quietly encode discriminatory value judgments about whose life is deemed worth saving, washing the bias in this, veneer of objective mathematics.
So what does this all mean? We have traced an incredible evolution today. I mean, we started with early 19th century battlefields where prioritization just meant stopping the bleeding fast enough to hand someone a musket.
Right.
Then we moved to the ABCs and Maslow's borrowed pyramid to balance physical and psychological needs.
Yep.
Then we looked at the brutal utilitarian math of disaster triage and algorithms, and it all culminates in where the profession is going right now. The sources note that the 2023 Next Generation NCLEX, which is the major exam all nurses must pass, has shifted its entire philosophy toward a dynamic clinical judgment model.
Yes. The exam has evolved beyond asking students to just memorize a checklist. It now tests whether a nurse can recognize subtle cues, analyze them, prioritize hypotheses, take action, and then immediately evaluate the outcome in a constant dynamic loop.
Because the patient's status is always changing.
Exactly. Prioritization is no longer viewed as a one-time decision you make at the door. It is a continuous act of reasoning.
And this matters so far beyond the hospital walls. I mean, the frameworks we discussed today, deciding who or what gets resources when there simply isn't enough to go around, they govern our entire society.
Oh, definitely.
They dictate how 911 dispatchers decide which caller gets the closest police car. They govern how the national organ transplant waiting list is managed. Even tech companies use these exact scarcity frameworks to decide which software bugs to fix first. Prioritization is just the universal discipline of making defensible decisions under pressure.
Which leads to a really profound takeaway when we reflect on this material.
Yeah. What's that?
Well, we look at extreme frameworks like Start Triage, where medics are forced to brutally abandon the most desperate, complex cases, the black tags, for the greater good. But if you turn that lens inward, it makes you wonder how often we unknowingly make that exact same black tag calculation in our own everyday lives.
Wow. How so?
Think about your workplace, your community, or even your own personal emotional energy. How often do we look at the hardest, most complex, most deeply entrenched problems around us and quietly decide to just walk past them.
We just put them in the black tag pile.
We do. We sacrifice the hardest challenges simply because we feel we don't have the time or the emotional bandwidth to fix them, choosing instead to focus on the quick, easy wins. We might be applying disaster triage to our daily lives, abandoning the things that need us most without even realizing it.
That is a really lingering thought. We walk into life expecting the clarity of an X-ray.
Yeah.
We want the world to be clean, binary, broken, or not broken. But the reality is that we are constantly navigating these diagnostic muddy waters. And when the machine is broken and chaos is the only constant, the most important skill you can possibly develop is deciding exactly where to look first. Thank you for joining us on this deep dive. We'll see you next time.